I certainly want to thank Professor Patrick Stiff for the kind invitation and the Leukemia Research Foundation I have witnessed their work in the community for many years. And I see how it has been evolving and bringing these events for the benefit of patients with cancer, especially here in Illinois. I'm pleased to see familiar faces, and I can tell that you look better and better. I'm pleased to see that. I see some new faces also, and I'm sure that at this point you look and feel tired, but hang in there, because just interact and you will see that there are people here that were in your position and they'll benefit from health right now. You cannot even tell that they were in treatment before. So my task this morning is to present in 20 minutes an update of multiple myeloma and then new therapies and new combinations and understandings of the disease. It's not to be an easy task, but I hope that to create a flavor of what is going on. And I can assure you that I'm bringing good news. The first thing that I want to mention on these slides, now there are about 30,000 new cases that are identified with a newly diagnosed multiple myeloma. When Dr. Patrick Stiff and Dr. Vinugopal and myself were studying our practices not too long ago, the numbers were 20,000. So certainly we have an increment that responds, one, to more awareness of the disease. People look more for this diagnosis, and also because we have been more flexible in the diagnosis of multiple myeloma in order to capture patients before they get harmed by the disease. And I'm going to explain a little bit more about this concept. So it's a sensitive disease to treatment. It's not curable yet. However, it's becoming a very chronic disorder. And I think that the future is going to be that based on characteristics of the patients, the treatment is going to be more tailored, more directed to this specific condition, taking in consideration the patient, the performance, and the biology of the disease. So this is an update of the diagnosis of multiple myeloma, as I mentioned before. Initially, it was kind of a clinical pathologic diagnosis. You had the biopsy. It's a disease of the plasma cells that basically is a malignancy of your immune system, but you needed some clinical manifestations in order to come up with the diagnosis of multiple myeloma. For example, you needed the plasma cell disorder, and also what we call the CRAB criteria, which is an involvement of your renal function or anemia or bone disease or elevation of calcium. So this has been evolving in order to prevent, as I said, patients from getting harmed and capture patients at an early stage in their evolution, because multiple myeloma starts from a dormant phase and then become more active, advanced, faster, and can cause clinical manifestations or involvement. So once you have the diagnosis, what you try to do is to predict the future. Which patients will benefit from an intensive aggressive therapy, which ones you might be more conservative in the treatment. And in that regard, we rely on a couple of staging systems. Duri-Salmon staging system, it was published for the first time in 1975, if I don't remember. Yes, 1975, if I don't remember wrong. And taking into consideration those clinical manifestations of multiple myeloma was taking into consideration your renal function, how high the immunoglobulin was, the protein that is coming from these cells, if you had involvement of the skeleton, how many sites, etc. It was slightly complicated, and even though was able to tell you how much myeloma that person had in his body, was not so reliable from the standpoint of survival. Sometimes you have patients with a very limited involvement, but the progression was very aggressive. On the other hand, you had some patients that they had an extensive involvement at presentation. However, the disease sometimes became indolent, relatively speaking. So in order to come up with a better way of predicting the future, there was an international effort, and they came up with the international staging system for symptomatic multiple myeloma. And they look into many variants. They look into renal function, the stage of disease, age, etc. And what they found were two independent, well, they found more than two, but the ones that are easier to pursue are beta-2 microglobulin and albumin. And by combining these two, they were able to come up with a staging system in where if your beta-2 microglobulin was almost normal and your albumin as well, those patients were categorized as a stage 1, and the median survival was about 5 years, a little bit over 5 years. On the other hand, if your beta-2 microglobulin was higher than 5.5, your survival was less and the prognosis was worse. That said, this staging system was established based on patients who were treated in the 90s. And in 2000, there was a revolution in the management of multiple myeloma because there were other drugs that were found and developed, and they were working better than the standard of care. So something that we need to understand is that when we're talking about survival, be careful with that, because that survival is based on the medicines that we have at a certain point in time. And these patients who were treated in the 90s might not represent what we have today from the standpoint of treatments and benefits. Actually, what you see at your left is a validation, it's an update of this staging system in where they consider novel agents, novel therapies. And the outcomes are getting better. The system, though, still stratifying patients into those with a more aggressive disease and those in where you present with a more indolent type of multiple myeloma. So the progression continues occurring, we're evolving, and the outcomes continue getting better and better. So we have a better understanding of the clinical manifestations. We have also a better understanding of the pathophysiology of multiple myeloma. So how these cells are going to behave depending on certain variants. Fortunately, it's not too complicated, as you can see here. So, no, but I mean, and actually this is a simplified cartoon. But it's better than what we understood before. For example, this circle that you see represents the plasma cell, the myeloma cell that developed this proliferation, this malignant condition. And what is important to see in this slide, rather than memorize the pathways and proteins and interactions, is that the myeloma cell is going to interact with the microenvironment, with those microscopic cells that surround them. And we have here actually 4 groups. We have the endothelial cells that are kind of the lining of your vessels. And through that interaction, the plasma cell becomes immortal, but at the same time, it's causing some changes in our system. We see the same thing with, for example, osteoclast and osteoblast, which are cells that keep the homeostasis or the balance of your calcium in your body. And in order for the myeloma cells to become immortal, because that's basically what is happening, it's going to be causing some changes in your bones. And by stimulating those cells that keep this balance, indirectly they cause this involvement of your bones, that it's going to be like holes. Your bones become like a Swiss cheese. And that is with the intention of nourishing themselves and continues their progression, proliferation, and evolution. And at the same time makes those cells hyperactive. And that is the reason why we use sometimes biphosphonates like Someta, pamidronate, in order to break that cycle. Another important interaction is with your immune system. You see lymphocytes, especially the T cells, lymphocyte T, the natural killer cells are going to be suppressed because they are the surveillance of your body. When you develop a cancer cell, that immune system interacts with those cancer cells and eliminate them, unless the cancer cell finds a way of suppressing this immune system that is supposed to defend you. And last but not least, the stroma or the niche, the nest that support cells interact also with the myeloma cells. The myeloma cells call them, they respond back and maintain this cycle of progression and proliferation. We understand also that initially our concept of cancer was that one cell became malignant and then proliferate, make a twin daughter and those or sons, and the proliferation continues and they were identical. That is almost true. We know now that we have initial stage in the cancer development, and this actually applies to other malignancies, not only to multiple myeloma. But when you have that initial phase, you might have more than one clone. At the top, you see the blue circle, the single red circle here. And once become malignant, it's because one of these cells became dominant. And when you treat these diseases, you can eliminate that clone, and this might be a survival clone or surviving clone that at relapse is going to be manifesting itself. You have the other possibilities, which is that the initial clone is the one that is progressing, or one from the ancestral clone that can now become the dominant and give you quote unquote another variant of multiple myeloma. So this model explains several things. Why sometimes after treating a patient with a certain combination, you can go back and that patient might respond to the same therapy. Another concept here is that when you combine more than one drug, you usually have a better response because you are attacking subclones from different angles and with different mechanisms of action. So common treatment for multiple myeloma, you have the immunomodulatory drugs, the proteasome inhibitors, you have the monoclonal antibodies, alkylators, and steroids. For the most part, those are the ones that are approved by the FDA. There's other drugs that are kind of in development and probably are going to be available very soon. But these are the most common at this point. And as you can tell by taking this drug from different family of treatments, you have a soup of letters here that can represent different combinations that can be used in multiple myeloma. So sometimes it's not so easy to come up with the first treatment or the treatment that is more appropriate. And let's keep in mind that when you select a therapy, you select based on the biology of the disease, if the disease is aggressive or not, and the performance of that individual at a certain point in time, and those are moving targets. Someone who is not in good fit at the beginning might be in excellent shape after several treatments, and vice versa. Someone who started in a very good shape at relapse might present with some medical conditions that might indicate that we need to switch therapy. So that keeping that in mind, we try to guide ourselves by what we call randomized studies. Those studies in where by random you put patients in one group and then in another group, and you try to compare outcomes in a prospective way. Those are probably the best studies. And we have, for example, the first study that you have on the top by Terry Falcon, compare melphalan, prednisone, and thalidomide. Melphalan and prednisone, those two drugs, the alkylator, and up to this point I can tell you that the best drug as a single agent in multiple myeloma from the standpoint of response is melphalan. There's no drug at this point that reaches the response as a single drug as melphalan. So melphalan prednisone was kind of the standard, and there was no other combinations better than melphalan and prednisone until thalidomide was discovered, because it was on the shelf from prior years, and was added to melphalan and prednisone. And suddenly, that was probably the breakthrough. For the first time after many years, they saw a survival advantage. And then came a second line drug, Revlimid or lenalidomide was similar to thalidomide, so made a lot of sense to compare lenalidomide and dexamethasone versus melphalan, prednisone, and thalidomide. And as you can see, the survival was better for the lenalidomide and dexamethasone. There was a phase 2 trial by Dana-Farber, Dr. Paul Richardson. He decided to add then bortezomib or Velcade to that Revlimid and dexamethasone, looking for a better treatment. And he published a phase 2, means it was not compared against anything. But Brian Drury came up with a combination of VRD, or Velcade, Revlimid, and dexamethasone versus RD, that remember was the winner from our first trial. And he found out that, in fact, the combination of these 3 drugs was better than our RD. So now we have a better combination composed of 2 novel drugs with the steroids. And in the meantime, there was a French group, Philippe Moreau, that used the thalidomide that we had at the beginning with Velcade, and also found a better outcome. Last but not least, Michel et al. From France as well added transplant. And I can tell you that in any combination, no matter how strong it is, stem cell transplantation always add a percentage of response that is about 20% higher. Even in combinations in where is so potent that you have to go for minimal residual disease because your standard therapy or your standard diagnostic tools are not good enough. When you look into MRD or minimal residual disease, you improve if you use stem cell therapy after your conventional treatment. These are combinations of drugs that has been used in newly diagnosed patients with multiple myeloma. And as you can see, 2 concepts here. Probably the most important concept is that 3 drugs appears to work better than 2. And you see sometimes 3 drugs here, but when I'm talking about 3 drugs, I'm talking about the combination of 2 novel agents, and steroids are usually part of every system. Dr. Linda Burns showed, this is a slide from the CIBMTR showing the most common indication for stem cell therapy. It is still plasma cell dyscrasia. We have a slight amount of patients who go through allogeneic transplantation. I believe that there's a role for stem cell transplant in patients with high-risk disease, others who have a relapse shortly after stem cell therapy. There's a trial right now supported by the National Cancer Institute and through the CTN organization, in where they are transplanting patients with donor stem cells, allogeneic transplant for multiple myeloma. I understand it's open at Loyola. We are opening the trial as well at Advocate Health System, and I think that is a very exciting trial that people should consider participating, of course, as long as you have the indications. So, in regard to transplantation, some of you that have been visiting transplants in some centers, they might be pursuing tandem transplant, for example. Some others are going to say, well, tandem transplants are not necessary. There's a CTN trial, there's 0702, that was close to accrual because the data is complete, and came up with some answers. There was a randomization after stem cell therapy. So everybody in this trial had a first transplant using melphalan at high-dose therapy, that is the standard, and then they were randomized to just maintenance with lenalidomide. They got 4 cycles of a novel regimen, Revlimid, Velcade, and dexamethasone, or they went for that second transplant within 6 months, what we call a tandem transplant. Everybody got on some maintenance with lenalidomide. And what we saw from this trial is that there was no difference in overall survival among the 3 approaches after transplant. There was no difference in progression-free survival. And the incidence of secondary malignancies appears to be similar as well. That said, we need to be careful with this overall survival at this point, because the follow-up is not long enough. And in my experience and everybody else's experience, the differences in survival in myeloma, usually you see it after several years down the road. So at this point, there's no survival advantage. That said, what makes more sense based on the data that we have available is to go for maintenance after stem cell therapy. And I reserve, for example, the consolidation with a combination of novel agents like this RVD, the one that you have in the middle, when there's some residual disease after transplantation. And some of the patients who receive lenalidomide with residual disease can respond as well. So about a year and a half, the FDA approved several immunotherapies for different disorders, as you see, for neuroblastoma, colorectal cancer, melanoma. But for multiple myeloma, there were two monoclonal antibodies that were found to be effective in patients with relapse or resistant, refractory multiple myeloma. Those are daratumumab or Darzalex or elotuzumab or implicit. So the first one, elotuzumab, is a monoclonal antibody that is directed against CS1. It's a protein that is overexpressed in the surface of these myeloma cells. It's part of a combination, it's part of a family of a protein that is called a SLAM, or a SLAM family 7 is another name from this protein, or signaling lymphotoxic, signaling, I had something coming here, but signaling lymphotoxic antigen modulator. And the way that this works is that elotuzumab, as other monoclonal antibodies, not only attaches these proteins on the surface of these cells, causing changes in the internal part of the cell that lead into cell death, but it's also calling other cells that are part of the immune system and direct them to attack the myeloma cells. This concept from the bench research, from the laboratory, was taken into clinical trials. And what we have seen is that these drugs not only work well in the lab, but work also in the clinical setting, especially if you combine them with other drugs that have been already used for patients with multiple myeloma. For example, this is the ELOQUENT 2 trial in where they combine this elotuzumab with lenalidomide and dexamethasone. As you can see, the progression-free survival, which is the dark line on the top, is better than when you compare this just with lenalidomide and dexamethasone. I want to clarify that these graphics are about progression-free survival. This is not about mortality. It's not that these patients necessarily are dying when you see this curve coming down. It's that sometimes patients are actually asymptomatic and you see the proteins that are coming from these cancer cells going up, and that is considered a relapse. 25% in two different tests separated by 2 weeks apart. That makes your definition of progression. So daratumumab or Darzalex is kind of a similar approach with a monoclonal antibody. Has different ways of killing myeloma cells. They have a direct way where they call apoptosis. They can also call an antibody-dependent cytotoxic or cellular cytotoxicity, and they basically label your myeloma cell and attract the macrophage, monocytes, natural killer cells, and they eliminate this the malignant cell. They also can cause a complement, which is a bunch of proteins that are going to make changes in the cell membrane, causing some pores, and then eliminate the cells. There have been clinical trials as well. In this one, in combination with Velcade and dexamethasone, seems to be better than Velcade and dexamethasone from this standpoint. Again, progression-free survival, overall survival in patients with refractory resistant disease is fantastic. I mean, we're talking about 90% a year and a half later, free of mortality. So when you have all these options, there have been effort in trying to make some common sense in all the options that we have available. And one that in my opinion is one of the best guidelines came from Dana-Farber, Dr. Ken Anderson, and he presented that last December. He divided patients between those who were on maintenance after their therapies and those who were off therapy, and then further subdivision into those who are in good shape versus those who are more frail, or they have an indolent relapse, those who, for example, just chemical relapse. And if they are in maintenance with thalidomide, the concept is that you go through a second line of immunomodulatories like lenalidomide, Cyborg-D or Cytoxan is kind of a combination that is very well tolerated. It's almost in every step on this algorithm. If patients are on lenalidomide, they of course they go for other lines of therapy like pomalidomide and carfilzomib, which is a second generation of proteasome inhibitors, now have a role. Some of these regimens are more aggressive than others. There's correlation with more side effects than others, but certainly we have several options when they are off therapy. We have new drugs like exotsimib, which is an oral proteasome like Velcade, but it's not Velcade. I want to make sure that we understand that oral proteasome is not oral Velcade. We have elotuzumab that has been used also in indolent relapses or frail patients because it's very well tolerated. So, what is new? There's several approaches, several drugs that have been already tested in other malignancies, and checkpoint inhibitors is one of them. Has been approved for lung cancer, has been approved for Hodgkin's lymphoma, and now there are trials in multiple myeloma as well. And that is this part of the cartoon. This is a myeloma cell. These are cells of our immune system. So remember this escape phenomenon where your T cells, your lymphocytes that are supposed to protect you are no longer able to do that. That is because there's a normal mechanism in our system when we're talking about the immune system. If you are invaded by a bacteria, your immune system is going to kill that bacteria, but there's going to be a break. Because otherwise your immune system is going to eat your flesh, right? So you activate your immune system and then deactivate your immune system when you no longer need it. In these malignancies, they adopt that system to break the immune system, and they internalize that system and they start fooling your surveillance. So now your T cells are no longer capable of attacking the cell because they are in a break mode all the time. That break mode is mediated by this PD-1, PD-L1, and PD-L2 system. And there are drugs now that are able to block that break and have your immune system moving forward again, directing your T cells and your natural killer cells into the attack of that multiple myeloma. There are trials on this with this approach. We need to make sure that we observe closely the toxicity profile. As you can imagine, someone with an autoimmune disorder that is exposed to a drug that activates the immune system, that might not be the best approach. But we need to be careful because the immune system has ways of counteract that. So I'm not saying that someone with arthritis shouldn't, or rheumatoid arthritis should not participate in the trial. I'm just saying that we need to be careful and keep in mind potential side effects. But for example, there have been some reporting where graft versus host disease later on those patients who receive an allotransplant might be, the incidence might be elevated because they had an immune system that was provoked, was stimulated. The same thing with pneumonitis. That is an inflammation of the lung. We need to be careful in patients with, for example, Hodgkin's lymphoma, where they have been exposed to radiation therapy to the chest, some drugs that can be toxic to the lungs. So they get exposed to these check inhibitors, and now you move forward with a transplant. It's a combination that you need to be very careful with. So the CAR T cells, Dr. Steve has been involved in these trials, and it's a very it's a fantastic approach. Basically, you're taking these T cells and you are preparing them to attack the malignancy. You take the T cells out of the body of the patient through a vector that sometimes can be something similar to a virus. You penetrate and add to that T cells the information that they need in order to attack the malignant cell, and you create millions of those cells, and they are infused back into the patient. And that also triggers an immune response that is capable in some instances of eliminating diseases that are very resistant and refractory. I was able to, during my work with Dr. Steve, of seeing patients with lymphoma, for example, that they had diseases that were not responding to anything whatsoever, and you saw later PET scans that were beautiful. I mean, no single evidence of disease. Obviously, it's not the cure of these malignancies yet, but certainly it's moving fast and has been treated effectively patients with resistant disease. So I'm sure that once the technique is better managed, we're going to have even better outcomes once we move them up to early stages on the management of these patients. One drug, and I'm almost done, that you have seen from Dr. Larson, Dr. Venugopal, that have been used in leukemias, in CLL, has been tested in multiple myeloma as well. And it is actually, these are patients with relapsed, refractory, resistant multiple myeloma. And when you use this as a single agent, you see a benefit that, interestingly, is observed more often in patients with a translocation 11-14. Fortunately, this translocation is not so rare in multiple myeloma, actually. You can see it in patients with a standard risk. You don't have to have a high-risk disease. So when you look into the whole population, you saw responses in the order of 21%. When you separate patients with the translocation 11-14, that went dramatically high, 40% respond, again, in patients who had refractory disease. That is really very, very encouraging. And last but not least, effort, one of the new targets, we're talking about April, so it's not May, it's not March, it's April, and it's a protein that goes and attaches this B-cell maturation antigen. This brown color that you see here is test that you do to detect this B-cell maturation antigen. And and as you can see, almost all the cells are positive for this antigen. And when this ligand, is a proliferation-inducing ligand, attaches this B-cell maturation antigen, that creates proliferation and progression. So they are now drugs that interfere with that stimulation, blocks that stimulation, and enhance, not only stop the proliferation, but then enhance the sensitivity to other drugs. So I believe that in combination is going to be very effective. The trials were just started this year, and I believe that of all the novel treatments that are out there, this is one of the most promising drugs. So with this, I would like to stop here. The conclusions that you can see is that the current therapies for multiple myeloma have improved survival. I mean, patients, no doubt, they're living longer. Now the median survival of a patient is about 10 years or longer. When we started, I remember when I was in my residency, it was 3 years. So it's going really fast. New treatment approaches are delivering outstanding results with the addition of immunotherapy. It's been used now and you can see you can hear the claps. I mean, they got very excited about this. So the rationale is to combine drugs rather than using only one single agent. The combination for patients is going to be more productive. It's going to be more beneficial. And remember, you can start very debilitated, very weak, and then escalate in the course of your treatment for a comprehensive and a combination of therapies. And these better outcomes, I'm repeating the same thing that Dr. Parameswaran and Venugopal said. These better outcomes have been achieved through participation on clinical trials. There were people like you that 10 years ago decided to go for the unknown, for the promise, and they got the benefit of participating on those trials, and they were the first one to enjoy the benefits of these new drugs. And because of that, we have this standard of care that some of you are enjoying. So the fight continues, participating in clinical trials that make sense. I mean, participation in clinical trials that have been designed in a rational way is of paramount importance, and we need to continue. And thanks to the Leukemia Research Foundation that not only promote the participation, they directly support the development of these studies. I think that is a wonderful, wonderful organization. Thank you so much, and good luck to everybody here. And I'll be around in case there's a question.